Okay, yeah.
journal clubs and stuff. All right, so this is the 7th Healthcare Journal Club, January 15th. I'm gonna be presenting on a novel treatment approach for diabetes mellitus type 2. We'll get started. Points, if you want to get points. Um, yeah, that's there. Uh, to do. Yeah, a little bit of intro to the Journal Club for those who haven't seen it before. The purpose of the Journal Club is to introduce you to published literature, get you a bit of a better research literacy in a very comfortable, low stress environment with fellow undergraduates. Um, and it provides you a space to practice presenting research, as this is a valuable skill if you want to go into medicine or go into the world of academia. Yeah, and exposes you to different areas of academia. Specifically, this is a healthcare club, but this could be applied to different areas of healthcare or even areas that are helping healthcare and collaborate with them, such as computer science or even industrial engineering in recent years. So the participation expectations. So you have had read the article before, at least skimmed it. Bring up your own ideas if they come to you. If you have any questions about methodologies, question them, and then the rest of that that are general good practice for being a student and also being a researcher. But we'll jump right into it. So the paper that we're going to analyze today is a review paper by Dr. David Owens discussing the clinical evidence for earlier initiation of insulin therapy in type 2 diabetes. A little bit of the background, there are two types of diabetes. So there's type 1 diabetes and type 2 diabetes. The first one is insulin sensitive and insulin insensitive. I'll actually go over a pretty, I put these pictures in the next slide, but the general idea of diabetes is that in normal function, the beta cells of your pancreatic islets, which are located in the pancreas, secrete a hormone called insulin, goes into the bloodstream, and it attaches to cells. Now, why is that important? The insulin is a key that unlocks the cell's ability to absorb glucose. And that is how our cells are able to get energy, function properly, and that's the normal pathway. In diabetes, that insulin key into a lock is disrupted. Maybe these cells are not sensitive to it, in which this would be type 2 diabetes, where there's still insulin in the bloodstream, it's just that the cells can't get access to it. Or in type 1 diabetes, the pancreas is just not secreting insulin, and the cells are ready for it, but they don't see any of it. So that's where you get insulin sensitive or type 1 diabetes. Now, the current treatments that are available go on a stepwise function. So there is the traditional initial diagnosis of diabetes leads to a recommendation of exercise and a change in diets to maybe eat less, decrease the incidence of obesity, maybe decrease high sugar foods. And that is to try to limit the amounts of extra sugar that you're ingesting in the body that it will have to process and put into the bloodstream. We're not going to go too much into the treatments of diabetes diabetes mellitus type 1, and so these are all going to be type 2 treatments. If this diet and exercise does not work, what is the next step is so drug monotherapy. The most common first line drug is metformin. Then they'll go into 2 or 3 drug combinations, depending on the clinical presentation of the patient. Maybe they have some risk factors that contraindicate the use of a different drug, but the physician and clinician will determine what drugs are best for the patient. And after they do the drug monotherapy, they do 2 drug combinations. If that doesn't work, 3 drug combinations. If that doesn't work, then it usually ends up at insulin. And there's a lot of steps in this process. Each drug combination is another visit to the hospital. It's another evaluation. It's time spent on this treatment. And what happens is that there's a phenomenon called therapeutic inertia, where the patient, their disease state might progress faster than what the treatments are allowing for, or how fast they can get to the doctor's to the clinic, and they might need insulin or maybe that three drug combination right now, but they're still stuck on metformin, and the doctor's considering doing two drug combinations. So the definition of therapeutic inertia is listed there as lack of timely adjustment to therapy when a patient's treatment goals are not met. So that is one of the driving factors of the current review. um, yeah, so going back to this, these are different classifications. There's also the classifications on that diagram, but they're pretty standard. They're set by governing bodies or governing bodies of clinicians that make recommendations for these treatments. A little bit of background on one of the papers that I found a little bit confusing. I had no idea what a hyperglycemic clamp was. And that is when you're injecting insulin into somebody at a constant concentration. So if you want to elevate their injecting glucose into the bloodstream at a certain concentration, making them hyperglycemic, and you want to maintain that concentration to measure the baseline functionality of beta cells, and that's to measure beta cell sensitivity. So that's a cool definition I found, and I had no idea what it was before reading this paper. So these drug combinations and therapeutic inertia is not one of the only things that are discussed in this paper. It's also that insulin is it requires a lifestyle change. Oral drugs are similar to, okay, let's pop an ibuprofen. Okay, let's take some acetaminophen, some antihistamines. It's very comfortable for patients to take oral anti-diabetic drugs, and those are easy. But diabetes requires blood glucose measurement. It requires that you are injecting yourself with diabetes, or you're monitoring a injecting yourself with insulin or monitoring an insulin pump. So this requires a lifestyle change, and a lot of patients are not comfortable with it. And part of that uncomfortability is that they might be on this treatment regimen and they're getting tired of it. They're on three drugs, and now you're asking them to do insulin therapy using injecting insulin or having an insulin pump. And that's a lot. So one of the benefits of, or one of the approaches that is discussed in this paper is if let's just go cut straight to the chase and start insulin therapy. So we'll talk about that through this club. Yeah, so the early initiation of insulin therapy has a couple of base level benefits. So with insulin, you inject it, it's an anti-inflammatory drug, and it's an antioxidant. There's a lot of oxidant reactive species in the blood, or ROSs, and the insulin suppresses them, so they won't react. These ROSs, they tend to damage endothelial cell lining, or like the walls of the blood vessel. So this insulin prevents that. So there's there's an anti-inflammatory component, antioxidant component, and since these endothelial cells are not being damaged or have a lower incidence of being damaged, it also contributes to a lower incidence of vascular disease, of diseases like aneurysms, like aortic dissections, like retinopathy, once it gets right into the capillaries and it causes blindness. So a lot of vascular diseases have a protective effect from insulin therapy. But those are the base level benefits of just insulin. I did not talk about the risk, but I will get there. But it's all started out with rats, dogs, and humans. Jenton et al. Had a study where they started off with what is the protein kinase B AKT? What is the role of that protein? And he was curious on what it does. So he took a rat model and he chopped off half its pancreas and tried to see what happened with the regeneration process. And what was found was that this protein kinase, it contributed to the formation of new duct cells. So in the pancreas, the beta cells aren't secreting directly into the bloodstream. They're going to secrete into the ducts, the pancreatic ducts. So these duct cells need to form throughout the pancreas to allow for that transportation. And the protein kinase contributed to these ducts forming and reforming. And some of them also differentiated because of this protein kinase into beta cells. So they did that experiment, and they found that this protein kinase is super important in developing into beta cells. Now, the next paper that was talked about, they talked about these clamps, these isoglycemic or constant glucose in the bloodstream, and then insulinemic, or they have a very high concentration of glucose in the body, and they compare that with hyperglycemic clamps. So they have the normal glucose, and then lots of insulin, and then the lots of insulin experimental groups. And they had the goal with that was to see what happens if you have exposure to insulin. And what happens is that there's an increased beta cell response down the line. So if you have hyperinsulinemia, then you have a increased beta cell, or those are the cells that produce this insulin. And then they get into the next paper. Garvey et al. Describes what happens if you take a group of patients and put them on high intensive insulin therapy, and the management of hyperglycemia. So when they did that, they saw that there was improved insulin secretion from the beta cells, and then also improved insulin sensitivity from the cells themselves. So that was great. That was a great finding. And the next paper that was discussed was, okay, let's move away from the pancreas, and let's talk about a condition I talked about a little earlier, retinopathy. And they use dog studies to see, okay, we have different groups of dogs. We treat them differently. I believe the groups were diabetic dogs that had poor treatment, diabetic dogs that had treatment later on in life, and diabetic dogs that were treated throughout their life really well. And what they found was that good control showed good control throughout the whole treatment. So they're getting their insulin. They showed no retinopathy, where the other two groups, they showed increased incidence of retinopathy. So that contributed to the discussion of, okay, if we have this great treatment, and lots of insulin, there might be a lower incidence of vascular disease. So that's a little bit about the early studies. After this, a lot of people try to get involved with these massive large-scale studies. We wanted this to translate to humans because a lot of humans have diabetes. So there's all these different studies, but all of them, they resulted in better glycemic outcomes. So these are all intensive insulin giving studies, and they show that there was a significantly lower HbA1c levels, which is great. This is a proven treatment. This is insulin is a good treatment for diabetes. And sorry, I forgot what I wrote here. And if you have this intense glucose control, there was little to no mortality changes among the control groups versus the experimental groups, and even in myocardial infarctions, there's a lower risk of myocardial infarctions, but these are non-fatal. I'm not too sure if they discussed fatal myocardial infarctions. So now we get kind of into these risks where when they're treating all these patients, they saw lots of risks of hypoglycemia. So this is low levels of glucose in the blood, and that can lead to really debilitating symptoms, and it's life-threatening. If you're hypoglycemic and you took way too much insulin, you could die because none of your cells are getting any glucose and your body ceases to function. So they did another study where they tried to, um, moving away from the hypoglycemia concerns, they tried to do a study where they compared just insulin and uh, oral drugs. And what they found was that this risk of hypoglycemia didn't really change. There was still the same incidence of hypoglycemia among both groups. So I guess, yeah, it did contribute to the hypoglycemia discussion. But yeah, these oral drugs, so the metformin, the sulfonylureas, and then the regular insulin. So there was little to no difference in risk of hypoglycemia. There's other couple of large scale studies that they talked about, but mostly they explored the same outcomes that insulin was a okay treatment for type 2 diabetes, especially in the early stages. Um, so they discussed more into the clinical evidence of why we should initiate insulin when they explored groups that just got diagnosed with type 2 diabetes mellitus, um, and they gave them insulin immediately. What they found was the beta cells even continue to function well as long as 3.5 years. If right immediately after diagnosis, this insulin was given. So that was it was a great finding, but there were some concerns I had with that finding where maybe the type 2 diabetes wasn't going to progress that much. And what if the beta cells were going to function as long as 3.5 years anyway without insulin? So I'm not too sure about that, but it has to have a contributing factor to at least extending the cells a lifetime a little bit. But then talk about a little bit about early versus late insulin therapy. And what was found was that we bring in the treatment uh, I forgot the term, treatment exhaustion. I introduced this term, but the patients were tired of their treatment, and the the rate of them getting this using their drugs, taking all these per day, it's a lot, and a lot of them have take it don't take it, and they get submaximal treatment from the oral drugs. So that was one group. So they had one group that was taking early insulin, and then one group that was taking just the drugs. But they found that after a while, they stopped taking all the drugs. But they saw that early insulin was better than no oral drugs or submaximal taking of the drugs. So if their patients were to choose, or if the clinician were to choose a patient with, or choose to treat a patient where they would take not all the drugs or just take insulin, insulin would have the better outcomes. Um, with yeah, sorry, treatment inertia is right there. Um, it it leads to higher glycemic burden. So like not taking all those drugs, then you reintroduce the risk of having hyperglycemia because you're not taking all those drugs as prescribed. Um, and it also talked a little bit about the risks of insulin again, the risk of weight gain. So you're taking up all that glucose and you gain weight. And then also hypoglycemia, where you take up all that glucose and you have no glucose left in the body, so you get hypoglycemic. Um, and yeah, that treatment inertia. So if you don't, along with not taking all the drugs as prescribed, if you are getting tired of all these oral drugs and you have to get insulin, it's like, oh, I have to do this. I'm not being treated as fast as possible. You have to go back to the doctor, and you might already be at the step where you require 3 drugs and you're still on metformin, or if you require insulin and you're still on metformin. Um, so that also contributes to the higher glycemic burden of where your body needs more treatment, but you can't get that treatment fast enough. So that contributes to the discussion of, okay, let's just treat with insulin early versus going through all the steps and exhausting all of them and having that treatment inertia. And a lot of other one other downside of taking insulin is quality of life. You know, you're taking your blood sugar every day. You are injecting yourself with insulin. Um, and that was a concern with clinicians. So they executed a study where they looked at the quality of life indexes among patients that take insulin versus going the normal route, taking oral drugs. And they found that there was no real decrease in quality of life measures among the patient population. So uh, it may or may not quell clinician concerns, but it showed that there was no decrease in quality of life measures. So after all this, there were some clinical recommendations for future research. So these recommendations were to look at three main populations for future studies, and that could potentially benefit the most from insulin therapy. One of these populations, so naive individuals, so treatment naive individuals, so people that haven't gotten any treatment for diabetes, and they show up in their HbA1c, which is a marker for diabetes, it's above 8.5%. And let's say, okay, let's have them, they're super, I don't want to say diabetic, but their HbA1c is really, really high. Now let's try to get them on early insulin therapy to try to initiate that B cell rest. And that B cell rest is just to say that these B cells are contributing a lot of insulin to the bloodstream. Now let's let them cool off. Let's let them not be so burdened by injecting that supplemental insulin, and to see if they if having them rest a little bit will allow them to produce insulin at better rates later on. There's also another a group of patients, so LADA patients, or latent autoimmune diabetes of adults patients. They're considered not type 1 or not type 2, but they're considered type 1.5 diabetic patients. And they require, or they progress to the insulin stage as really fast versus the other patients or other type 2 diabetes patients. And a recommendation is that, okay, if we have these patients that progress super fast, we don't want them to go through all those steps then to get to insulin. We want them to take insulin now and see, okay, now now we want to compare patients with that are taking the normal course of treatment versus patients that are immediately on insulin, and to see if that helps in their treatment and in their outcomes. And the last group that they wanted to explore was, okay, now we have these diabetic patients with a high risk of cardiovascular disease, whether it runs in the family, whether they have a condition like Marfan syndrome that contributes to it. We want to see, okay, now they're diagnosed with diabetes. Let's give them insulin. Let's see if how well this protective effect still lasts if we give early insulin, and to see the rates of cardiovascular complications. But yeah, that was a review paper. It's kind of long-winded. It's not very focused. It's kind of all over the place. But all of it contributes to the discussion and future recommendations for studies in patients or in giving patients early insulin versus the normal course of treatment with oral anti-diabetic drugs. But yeah, any questions?
Yay. You did a really good job going through the paper.
Thank
Because
you.
I thought it was long-winded as well, but at least the author did a good job of like segmenting parts of the paper.
Mhm.
Like they presented all the clinical evidence together, split that up just based on like each benefit, and then they grouped those studies. So it was yeah segmented, but and also thanks for talking about like what the current standard of care is for type 2 diabetes, because honestly when I saw the title of this paper I was like I thought that was what the standard of care was, you know, you are diagnosed with type 2 diabetes and you get insulin, like that's what I thought, because I don't know, I haven't looked into it, or I don't know anyone with type 2 diabetes. So my mom's pre-diabetic, but so that's good to know.
Yeah, I
Uh,
mean, one concern with this study is that it's only by one author, and this is probably some doctor that said, "Okay, I want to explore something. Let me write a review paper on on an idea I had," and they went through this all this literature and they evaluated all this literature. But what I'm kind of curious about is, has this review paper been cited by somebody else? Have people done more studies? Is this accepted in some professional society as a potential treatment pathway or a potential alternative way to treat diabetic patients? So it's a little shaky on the um, validity of their arguments, but I think it's super cool to think about. Dr. Babs put me onto this idea where, so I'm giving the type 2 diabetes treatment lecture for 256, and
okay.
it discusses the normal treatment pathway of the metformin, the sulfonylureas, the the receptor blockers, and then insulin. But then he wanted me to explore a little bit about the current developments in early insulin. Um, so yeah, it's interesting, but I'm not too sure how often it's used in clinical practice, but it'd be interesting to see if that develops more into as time goes on.
Yeah, I'm curious too. I mean, because this was published in 2013, and I was thinking about that as well. I How many citations does and now I was curious, like how many citations does this review article have? Or not citations, how many times has it been cited?
Yeah,
Uh, I'm not sure. It's like mm, eh, cited by, let's see. See all, okay, there's a list of cited by articles, but let me see how many. 30. It's been cited by 30.
yeah, maybe.
So, I mean,
Yeah.
that's decent. I mean, it's been like 10 years. That's
There,
okay.
oh, there is a more recent study in the journal called Diabetes Therapy 2020. Hmm.
Okay.
I don't know.
Um,
When I go through my lecture, I might introduce this, but I'm probably not going to explore too much into it
mhm.
beyond the normal course requirements. But I don't know. It's kind of interesting, and like the 2020 paper is a little more promising. Only 3 years ago, and they're still exploring it as an alternative.
Makes sense. Something that I was curious about in this paper was, let's see, let me reread this. Okay. So I'm not sure if this was part of like the Insight trial, which was one of the trials that used like insulin glargine or glargine, I don't know how it's pronounced,
Hmm.
but they studied or they studied normal fasting plasma glucose in people with early type 2 diabetes or
Hmm.
pre-diabetes, um, and like a high risk of cardiovascular events.
Hmm.
And they found, obviously, so they did find like the same risk of, there's a risk for weight gain
Hmm.
um, from early insulin, but they found that people with pre-diabetes treated with insulin were 28% less likely to develop diabetes, which was interesting to me because they talked about like the three suitable groups, right, towards the end of the paper, of
Hmm.
like treatment naive individuals, LADA, and high risk of vascular complications. But I was curious that, pre-diabetes, it was mentioned in one of those trials, but like the author didn't really talk about it after that. So
Yeah,
that's not what I've heard about, because usually for pre-diabetes, they say like, oh, exercise, diet, like change your lifestyle, right? So you don't get diabetes.
well, I think a reason behind that is that diabetes is expensive, right?
Mhm.
Exercise and diet change is relatively cheaper than getting on insulin. So I'm wondering if more clinicians would be on board with prescribing insulin or be more comfortable prescribing insulin if insulin was cheaper,
Yeah.
or even maybe if like they're always coming out with new patents of insulin, maybe even early treatment with a older patent, maybe a cheaper version of insulin, maybe that will yield the same early insulin results, and clinicians would be more comfortable prescribing it. So yeah, I think cost plays a factor into this, especially since the discussions on health equity are really ramping up to see, okay, we have diabetes, which predominantly affects lower income people, people that are exposed to larger food deserts,
Mhm.
that live in poverty, that have, that are just not able to support themselves as well as somebody that's more well off. If clinicians look at that and say, okay, I want you to stay on this treatment, or I want to give you a treatment plan that's feasible for you and won't bankrupt you. Um, so that might be a reason why clinicians aren't prescribing it as much, even though it might, like according to these studies, it might yield better results.
Yeah, that's not something that's discussed in this paper. Like they talk about the lifestyle challenge, right? It's a huge adjustment, but they don't talk about like the cost, the challenge of cost. Because
Yeah,
yeah, I know there is. I don't know if you've come across this in just social media, but I feel like recently I've heard a lot of people talking about like connecting sugar and just like living in a time of abundance where people are eating a lot of fast food or calorie dense foods that are cheaper, right? Like
yeah,
those, I feel like it's more expensive to live a healthier lifestyle. Like it takes more time and all
yeah.
that. Well, and so that they're talking about those factors and how that relates to like the increase of prevalence in type or the prevalence of type 2 diabetes around the world, right? Especially in developing countries, we're starting to see it more like
Oh,
recent.
definitely.
And so yeah, like all of that comes down to cost is going to be a major factor for a large percentage of people who are going to be affected by this, who don't have good control of the diabetes, because that's a huge factor, right? um, in reducing the amount of damage that's done. So yeah, cost has to be a big factor.
Yeah. Yeah, health equity really does play a huge role in this. And you talked about like lifestyle choices where, it has been shown that diet and exercise does work to an extent, and
Mhm.
it's so much cheaper than insulin. So if you can't change insulin prices via policy, or getting new legislation passed to control it, diet and exercise might be a way to to help treat type 2 diabetes. But yeah, there's not really abundance of choice. The easiest choice is to go to the corner store and buy some food. It's not to go to a supermarket that's 20 miles away. And I was at the Jerome Adams lecture yesterday, and he was talking about, all these people, if they have the choice, he believes that if people have the choice to eat healthy, to um, have these healthy lifestyles, to go out and exercise in a safe neighborhood where they're not afraid of crime, or afraid of danger, um, it might contribute. It'll be easier for them, and it might contribute to a healthier population, even if we can't control drug prices, or we can't control healthcare costs. At least, even at the lower level, or not the lower level, but the base level of community upbringing and upkeep, and just making places better to live. That might contribute to better health outcomes, especially people with type 2 diabetes. 'Cause there's so many people in poverty that are living, yeah, in these food deserts, in unsafe neighborhoods, in um, just not in locations where it contributes
Mhm.
uh, to healthy lifestyle.
Yeah, no, definitely. Actually, have you taken or like, there's a public health class that's called Diseases and Disorders.
No, no, I haven't.
Okay, so it's a common like life science elective in BME, but I took that class, and one of the things that we talked about is how often like ads for cigarettes, for example, are more often found in gas stations that are in low income neighborhoods,
Yeah,
and
no,
how exploitative something like that is.
no, he talked about that too. He talked about how Indiana hasn't, like, they have super high rates of, or super abundant advertisements for cigarettes, and also we haven't changed our cigarette taxes in forever. Like, we're still at like the minimum for cigarette taxes. And he was saying that in states where they've implemented higher cigarette taxes, there's a correlation with less people smoking. So, like, I mean, it's not like there's nothing being done about this. If you remember in recent years, Indiana, they raised the tobacco age to 21. It's not no longer 18. It used to be 18 back in 2018.
Yeah.
But yeah, I mean, it's not like they're not thinking about this, but yeah, there's a ton of cigarette ads in lower income neighborhoods, not just in Indiana, but yeah, all over the United States.
Yeah, it's I'm probably biased as well because I work on the National Suicide Hotline. So I talk to a lot of people who have a lot of problems like in their lives. And
Mhm.
even if you don't have too many problems in life, there's a lot going on in any given person's life. And, you know, and I completely, I can see the point about lifestyle as well. Like it's hard like to change your lifestyle. If you have so many concerns, you're thinking about like how to make enough money, you have to take care of your children, and you're having relationship problems, and you had like some trauma that you haven't dealt with, and that happened 20 years ago, and like all of this is just there and you don't even know where to start. Like people are just overwhelmed a lot. And so um yeah, it's just it's complicated.
Yeah, it is. I mean, they've been
Yeah.
studying it for decades. So, I mean, I think it's really cool to learn and to see how much has come out in the past 10 years on
Mhm.
this research.
Yeah, definitely. And the really interesting thing to me about medicine too is there is a large like behavioral aspect to it. And I hate exploitative ads. Like, I don't know if you're religious or not. Like, I mean, I don't want to say I'm not religious. I have like a
I'm
statue
not
of
I,
Krishna
I'm
right
not
here.
too religious, no.
Okay. But I mean, I'm from India. People are quite religious there. Um, I saw two ads this week. All right. I'm going to tell you. So, one of them I have a picture of, but it was a van. And in the back of the van, it said, the only cure to addiction is Jesus. The only cure, not the cure, the only cure. Like imagine someone like struggling with addiction, they're miserable, and they see this. And then I saw this other ad at Bennett's. Do you know Bennett's, like the greenhouse, like where they sell plants?
Uh, yeah, yeah,
Yeah. So I love Bennett's. Okay, I go there. I have a lot of plants, like
yeah.
you can see. But anyway, I have a lot of plants, and I love Bennett. But they had an ad that said cheaper than therapy. And I am like, wow, guys.
Yeah, I mean, it almost like trivializes resources, which is, I mean, it's kind of, it's like marketers always like to poke fun, but yeah, it's like that's the only stuff you see. So like you're in Indiana and you're driving down the highway, you're seeing all these billboards for Jesus this, Jesus that.
Yeah.
Because we're predominantly evangelical Christian community, and there's nothing wrong with that. It's just that um, people might get sucked into the thinking that religion is prevalent. It's a treatment strategy for mental health. It's a treatment strategy for this and that. And they might only think that, okay, you can go to church or you can live with it, where there's just so many different resources out there that
Mhm.
are being underutilized. And yeah, and also, probably underfunded. Um, to where they might be able to get that help with addiction, help with um, childcare, help with uh, knowing what to eat. I think like Indiana has a helpline where you just call them up and say, "Hey, I'm looking to use this ingredient. Is it healthy for me or not?" Things like that.
Yeah, that would be awesome. I mean, I guess like my bottom line point that I'm trying to make from all this is when you start to delve into something that affects a person's health and you're making and you're using it to market a product, that kind of gets, I feel like there needs to be some sort of limitation around that. Is if there's some sort of advertising and it's for a product or something that you know, relates to a health outcome, then it needs to be,
Substantiated.
up to what we what we know is scientifically accurate at the time.
Mhm.
Obviously there was a time when maybe tobacco wasn't studied that well and like people were smoking all the time, but now we know better than that. And so yeah, there needs to be more. Yeah, but it's hard, but I yeah, um but it is interesting that there are so many reviews, and uh, we're making progress. I'm hopeful about the future generally.
Yeah, me as well. But I think that's a good point to end off on. It's cool. I There's so much more to learn about this. Like going into med school would be just it opened up a lot more knowledge and to see, okay, maybe I didn't consider this or that, or maybe there's even research. It's just like stuff to Google. Like maybe I just didn't know to Google that. But I look forward to seeing more about what becomes of this. But Priya, thank you for joining the journal club. Um, and yeah, it's been a lot of fun. I'll end the recording now.
Okay. Oh, is it still recording?
Yeah.